evening. Good evening and welcome. Welcome to our live audience here at the Fulginiti Pavilion for Bioethics and Humanities, as well as our remote audience out there somewhere. I am Tess Jones. I am the Director of the Arts and Humanities and Health. And this is our first exhibit since March 2020. So it's a very special evening for all of us. I want to thank everybody, both here and remote, for their patience and their flexibility as we manage changing policies and practices that seems to happen, if not daily, weekly on our campus about safety, and as we find workable technology to be as accessible as we can. So we're adapting and we're trying to make this work. Before I talk about tonight's presentations, I want to thank the staff. They have stepped up in ways, and that includes learning new cameras and learning new technologies. So I want to thank our team, David Weil, Malia Himbert, she's over here off camera, Heather Clough, and Lori Monroe. They have made this work. And if there are any problems or slip-ups, it's not their responsibility. It's probably something that I've done. So just to let you know, I also want to remind you that there is a concurrent exhibit of Stigma and Survival. It's open to the general public at the Foothills Art Gallery in Golden. And the artist's statement, a video about him and from him about his work, and some of the images are available on our website. That is www.coloradobioethics.org. And you can also, for those of you out there, you can find that in the chat. So I'd like to begin by introducing our speakers, our panelists this evening. I'm going to begin with our artist, our guest artist, William Stoehr. He lives and works in Boulder, Colorado. Bill describes his art as the exploration of the fundamental issues of our time: intolerance, discrimination, addiction, and violence. And he explores those issues with their victims, witnesses, and survivors. Next to him is our curator, Simon Zalkind. Simon has discovered, devised, dreamed up, and made possible the 3 or 4 major exhibits in our campus gallery since we opened its doors in 2012 to over 60,000 visitors. Dr. Nora Volkow, who will be joining us remotely, she's joining us on Zoom, is director of the National Institute on Drug Abuse at the National Institutes of Health. NIDA supports most of the world's research on the health aspects of drug use and addiction. And Dr. Volkow's work has been instrumental in demonstrating that drug addiction is a disease of the human brain. As a research psychiatrist and scientist, she has pioneered the use of brain imaging to investigate the toxic and addictive properties of abusable drugs. And finally, Dr. Robert Valuck, who is one of our own here at the Anschutz Medical Campus. He is professor in the Skaggs School of Pharmacy and executive director of the Colorado Consortium for Prescription Drug Abuse Prevention. Dr. Valuck is a leading expert in prescription drug adherence and patient-focused outcomes. And he is passionate, as all of our speakers today, about improving the connection between people and their providers so that they may fully benefit from their medications. So let me tell you how this will work, how this will unfold this evening. I've asked our artist to open our discussion tonight with his thoughts and feelings about the exhibit, about his work, as well as about his commitment to art and advocacy. Following his remarks, Dr. Volkow will speak, and then Dr. Valuck will follow her. We will open it up at that time for a limited number of questions and comments from the audience here, as well as in the chat function. These questions should be especially directed to Drs. Volkow and Valuck. So we'll ask that you, especially in the chat, be mindful and respectful in the interest of time and our topic. The final segment of our panel will be a conversation, more or less distanced, between Simon and Bill. Simon will present some slides and talk about Bill's work, art historically, and then they can have a conversation. After that, we will open up for general questions and comments to both of them, as well as to Dr. Valuck. So with that, thank you again, and I'm going to turn it over to our artist, William Stoehr.
My sister Odine died. Her daughter found her lying on the dining room floor with a bottle of pills and a bottle of vodka. I wonder if things would have been different without the stigma. Emma used booze, pot, and meth in high school. After graduating from high school, she left home for more than 6 months. No one knew where she was. No one knew what she was doing. No one knew if she was safe. And no one openly talked about it. One day, she simply called and asked for airfare to come home. When she had the first of her failed back surgeries, prescription opioids invaded her body and mind. And when the pain continued, the doctors simply prescribed more pills to this now known addict. The trusted small-town family doctor said that her spinal afflictions were the result of her falling down when she was drunk, which she did, but he totally misdiagnosed the actual cause. And he just couldn't see beyond the drunk and the addict. He couldn't see this beautiful person. He couldn't see beyond the stigma. Emma called the same family doctor one time when I was with her, and she asked him to help her get into a rehab facility. She was ready. I listened as he said, "Oh, Emma, it's Sunday, and I just got home from church with my family. Call me after the office opens tomorrow." Emma ran to her room and slammed the door. This doctor, she was simply someone who had made bad choices in her life. She was an embarrassment. She was an embarrassment with 2 kids and an empty refrigerator. Well, AA didn't work. The first intervention failed. She was kicked out of her first residential treatment program for smuggling in alcohol. But on the 3rd day of a marathon heart-to-heart, as I talked, pleaded, cajoled, simply exhausting all of my ideas, from out of the blue, I promised Emma that I would paint her portrait if she promised to go to rehab. She agreed. And for 5 years, she seemed to be in recovery. It was wonderful to see her laugh, smile, work in the garden, go fishing with us. But then her beautiful husband died. Then more back surgeries, more pills. She relapsed, she died. That was 9 years ago, almost to the day. In '65, I was 17, and I wanted to be an artist. For various reasons, I did not. 40 years later, I quit the best job I ever had to become a full-time painter. I figured I was still young enough to start a new career, and why not do what I wanted to do when I was 17? At this stage in my life, I could afford to define success in my way, but it took a few years to recognize my mission and artistic direction, to find my voice. Well, my voice found me, and it was in the back of my head whispering, what good is your art? What does it really accomplish? Does it even matter? So then I started to broadly explore victims and survivors of war, discrimination, violence, abuse, bigotry, addiction, and the list went on. And viewers interpreted my work within their own subjective context, related to their own experiences. And this is exactly what I wanted. But again, that little voice whispered in the back of my head, how can you honestly relate to all of these issues? Well, I can't. But I can relate to addiction, not as a victim, but as a witness. And I know about stigma. Families are embarrassed, communities judge, doctors are dismissive, and the addicts think they are not worthy. Worse yet, evil. Stigma is a barrier to prevention, diagnosis, treatment, and recovery. So stigma became the very tight focus of my art. Emma, my sister, OD'd, but maybe to the millions affected, I could be part of a solution, and stigma was the place for me to start. With alcohol and drug abuse, it's never just one person that's impacted. And so the faces I now paint are the faces of those affected, the victims, the witnesses, and the survivors. I think the first step to alleviating stigma is helping people understand that substance use disorders are a treatable medical condition and not a moral failing. When people come to my shows now, they are passionate about the work. They react passionately. They share their heartfelt stories. They paint a picture of suffering, terror, anger, chaos, and helplessness. But they also describe resilience, forgiveness, and hope, and that drives me. Some say they intend to take that first step to finally start that intervention that they've been delaying. Some, and this is probably most, thank me simply for recognizing them. I exist. I am not alone. I believe in the power of art to help break down the stigma of addiction, and I am motivated to take my art to the next level in that service. Now about my art. We see with our brains. Our eyes take in a puzzle of light, lines, and shapes, and our brains pull it together, figure out what it is, and then decide how it feels about it. Recognition, narrative, and response, probably not in that order. I am most interested in something neuroscientists call higher level ambiguity. Vermeer, we're all familiar with Vermeer's Girl with a Pearl Earring. It's the perfect example of higher level ambiguity. Vermeer has set the stage for you to complete the narrative. Is she inviting? Is she frightened? Is she innocent, pure, or seductive? Vermeer created an ambiguity that results in mutually exclusive emotional responses that at any one time to us, the viewers, seems very real and very correct. And over time, it changes. It changes with each viewing. You see the painting in the morning and you see something else. You are certain about how you feel about the painting one moment, and then later you feel differently. Now, I look to cause changes in visual perception and emotional response through methods and styles in order to create this higher level ambiguity. Starts with faces. We're attracted to faces, right? That's the first thing a baby looks at is the faces. It's in our nature. And then eyes dominate and hold your interest. So I create elevated intimacy with something I call a shared gaze. Now, I don't mean you just look at something. I mean you engage with those eyes, and that's a shared gaze. I also use iridescent and metallic paint that changes with lighting and view angle. And I frequently paint multi-views or multiple and facial features just slightly out of alignment. The faces are big, 7 feet tall. They're big, but somehow intimate. They change as you move into the painting closely, and then you move back. When you retreat, they become a different painting. Now, I know my work has an emotional impact, and it's ironic that this is something that I can influence, but not control. I no longer own the painting the moment it is experienced, completed, and interpreted by you. This is your reality, born of non-linear emotional experiences, traces of the past, and mental images triggered by the cues I present you. It is a reality which goes well beyond simply observing an image. In other words, can I entice you to not only interpret my paintings as illusions of reality, but instead cause you to perceive and experience a reality of your own making? You make it real, and you will do a better job completing my painting than I can. You do it with your own perfect mental image. So my job is to give you those cues to trigger that. I want you to feel with certainty before you think. And then I want you to have new and different experiences over time, each time you recreate my portraits with your own mental image, narrative, and state of mind. I have more than 300,000 social media followers. One woman wrote and said after seeing a painting of mine online that she knew exactly that I understood how she felt. And she said she wanted to die. Next morning, she looked at the very same painting and this time saw hope in the woman's eyes. She then understood that she too could have hope. And she said to me, "You saved my life." Emma, my sister, she said that she was evil. Oh my, where did that come from? No, you're not evil. No, you're not alone. Yes, we can discuss this. Yes, we can get help. Yes, there is hope. There is hope because of all of us. I believe finding the answer to stigma and addiction will take a groundswell from artists, poets, playwrights, writers, teachers, doctors, scientists, elected officials, and all of us, all of you. Thank you.
Thank you so much, Bill. And now we will hear from Dr. Nora Volkow.
Good evening, everyone. It's here from Washington, D.C. It's 7:50 and it's raining outside and it's dark. And as I'm listening to Bill speak and actually making me think in terms of how extraordinary an opportunity it is to bring two of the, I think that humans do, to the activities that humans do that actually enrich our lives and save our lives. On the one hand, art, and on the other one, science. And as we're all dealing with the uncertainty, the loss of loved ones because of the COVID pandemic, I think that we've all become increasingly sensitive at how important science is, because we rely on our ability as individuals to bring together knowledge and integrating our efforts to come up with solutions. But for these actions to take place, we have to have the emotional response that goes to want to try to help others. And I think that in terms of that I find so valuable about art is that addiction is a very, very stigmatized disease, and it's very hard for people to understand it. Even if you've never had cancer, if you have someone that's suffering from cancer, immediately generates an empathy, immediately generates this sense of wanting to help. On the other hand, if someone has addiction, it basically generates rejection. And as someone, I'm a physician trained in medicine, one of the aspects that always frustrated me was, why can we not feel the same way towards compassion for someone that is addicted versus someone that has other diseases? And I thought a lot about it because it's in a way understanding that difficulty that people have on taking the science. The science has shown, and we've been able to actually identify and characterize the changes in the brain that actually lead for people, that ultimately result in people losing control and this intense desire to take the drug at the expense of things that rationally make absolutely no sense. So people lose their children, people end up in jail, people end up overdosing again and again because the desire is so absolutely intense. And so since we're looking at it from our eyes of being in control, if we haven't been addicted, that generates a distance that is harder to bridge. And I'm always thinking, how is it that we can communicate? And I've come to realize that it's not just about communication, it's how can I make someone feel and understand what addiction is. So when I look at the images that Bill does of his sister and others, there is such a depth in understanding in that. I mean, his ability to capture that emotional depth and turmoil that exists in someone who cannot understand why they cannot control this urgent need. And just put yourself in that state of mind. You don't want to do something. I mean, you just say, I don't want to do it. And yet you cannot carry it through. You are unable to control your own self. And that generates a lot of hatred towards one's own person and dismissing and self-stigma. That is one of the hardest things to deal with for people that suffer from addiction, because they withdraw more and they become more and more dependent on drugs. So I see the value of art because it has a means to actually take the scientific knowledge and bring it into the emotional plane. So it's not only that I understand that the area of the brain, the frontal cortex, which is what allows me to focus, make decisions, and carry through. My limbic brain, which basically reacts when something is alien, which I can actually regulate with my frontal cortex. And that's why when we all get angry at someone because they insult us, we can calm ourselves down and say, no, it's not worth it. That is disrupted by drugs. So you lose that component of your brain. So if I explain it to you like that, it is extremely difficult to actually generate an insight of what it means. And my story is different from that of Bill, in that the history of addiction in my family is for alcoholism on my mother's side. And my grandfather and uncle, both of them were alcoholic. I never met my grandfather because he was in Spain. And my mother had emigrated to Mexico. And so I just knew that one day there was a telegram that arrived to the house, and I heard my mother went into the room, shut the door, and started to cry. And then the next day I learned that he had died of basically that his grandfather had died, but I never knew why. And I didn't know until I was already an adult and my mother was dying from ovarian cancer, that she told me, my father was an alcoholic and he actually committed suicide. And I was shocked because I had been working, my mother knew that I was working in terms of the science of addiction to communicate it and treat it as a medical disease. And yet the stigma was so prevailing that she didn't even allow herself to communicate this to me. And my reaction was, what is it that I'm doing wrong? Why is it that if I say, you know, it's a disease of the brain, just like diabetes is a disease of the pancreas, why don't I generate the same reaction? Why is this not impacting on the way that people react to the disease and a willingness to help others? I think that the aspect that makes it very, very distinct is that it's much easier to understand the pancreas than it is to understand the brain. And to even understand that very simple question, why is it that certain people are vulnerable to drugs? What is in their biology that leads them to have this compulsion and vulnerability? What happened in their lives that makes them more vulnerable? And it is clear that each one of us is different. And it is clear that if we have the genetic vulnerability for addictions, it doesn't make us less than someone that doesn't have it. It gives us a different perspective in life. If we know that we have that vulnerability, we can actually be proactive to prevent situations of danger. Like it's like my case where I know that I have a family history. With that insight, you can change your own behavior. But how do then I communicate just the science about why is it that a person, most people take drugs and they never become addicted. And yet there's a person who gets exposed and then goes down the road and in some instances dies from it. We've learned a lot. We have treatments that work. We have preventions that work. They are not applied. And they are not applied for many reasons, including the fact that there are many roadblocks to bring treatments to those that need them, such as level of reimbursement. And this is stigma for the disease. We're actually not treating them the way same because there is tremendous discrimination. And something that has been very tragic to see with the COVID pandemic, you see the healthcare system saturated by the challenges of dealing with patients. That, on the one hand, can bring the best of us to try to help others, but in certain circumstances can bring also discriminative practices. And we've seen during the COVID pandemic an exacerbation of the problems that people that are taking drugs are having to deal with. And that mortality has gone off the roof. And that mortality is in part a sense of the isolations and the despair and the lack of support. As I think about all of these things and the importance of art to communicate what it feels to be addicted, to generate empathy, I also realize that the other extraordinary value of art, it gives us a group experience. It's something that we all share together. And in terms of what makes us vulnerable, what are the factors around us that make us vulnerable? One of them is the loss of feeling part of a group, of meaningful relationship. One of the most powerful things that we have as humans overall is each other. And to the extent that each other relationship becomes discriminatory, stigmatized, it actually turns from being something very positive in something very negative. And I believe that yes, science can help us understand, but we need art to help us help others feel what it is to be addicted. Thanks very much for your attention.
Thank you so much, Dr. Volkow. We really appreciate your comments and your participation. And now I'm going to ask Dr. Valuck to step to the podium and present his remarks.
Thank you, and thanks everybody. It's a real pleasure to be here, and it's also a real challenge to follow Dr. Volkow and to follow Bill because they're just tremendous. The artwork, Bill, you know, it's extremely provocative. It really is terrific. Some of the things that you described, I'm as the least artistic person in the room. I'll be the first to admit that. I'm a numbers person, I'm a math geek, I'm an epidemiologist and pharmacologist by training. So it's all about numbers and science. And that still is some of the most powerful, images that I've seen. And just as he's able to describe and articulate to get me to think, to ask, and to feel. Things going well beyond, all of the training with, how things work. Nora is the smartest person you'll ever meet in terms of the science of addiction. She's brilliant and can convey that. But my work has been in the last 10 or 15 years, working across the state to try to work with communities and work with people to try to solve this problem, the opioid crisis. I spent the better part of my career trying to do that. Have members of my family who have died from drug overdose. So very, very personal experiences as well. And knowing the isolation and the difficulty that feels. But something that Nora mentioned that I wanted to highlight and take a step further is that a lot of people think the opposite of addiction is treatment, when she was really going down the right road, that the opposite of addiction is connection. Many people in recovery will tell you that. It's all about connecting with one other person, with a group of people, in a community of people. So we spend a lot of time in our work, the statewide task force that I work with, working with providers to try to educate them. So they will not see patients in a stigmatized way. So they will try to break down stigma and provide access to better treatment and opportunity for people to achieve sustained recovery and get their lives back. To prescribe better, not let people get into those situations in the first place. To work with public awareness campaigns to try to raise people's understanding of this. It's extremely difficult to do. It's akin, I think, to trying to turn an ocean liner around very quickly. It just does not happen quickly. As hard as you might turn the wheel, it turns extremely slowly to bring the bow of that ship around and try to go the other direction of understanding and educate everybody. And then in these times that are so polarizing, where science is questioned and science is not viewed in a way that can bring people together, science now is a wedge issue to drive people apart. It's a very difficult situation when our message needs to be what Nora said, which is addiction is a biological, it's a brain disease. It's treatable, and we can prevent it, we can treat it, and people can and do recover from it. We just have to simply bust through addiction, stigma related to addiction. It's our number one problem. People talk about we don't have enough funding, and we don't. We don't have enough access to treatment, and we don't. We don't have a good enough job educating all of our provider base coming out of training programs and all of the providers that are out in the field. True, we do not. Public awareness is not high enough. All true. All of those are true, but the biggest barrier is stigma. The most effective we can be and the most effective we've been able to be is to talk to legislators, to talk to other policymakers, to physicians, and simply bring this to the level of the individual. And again, have them feel. Once they feel this problem, they can do better. And I think that's the message for all of us. We can do this. I hope you will. Today it renews my faith in the ability for us to connect in another way. I'm learning another way and want to tell everybody to see Bill's paintings and images to get them to think and feel and act. So hope you'll all share in that and thank Bill for what he does. Thank you.
Open it up. Whoa. We are going to open it up. We're going to bring Dr. Nora back, and we're going to open it up for some limited questioning to Drs. Volkow and Valuck around some of the medical, scientific, clinical, pharmaceutical issues. So I'd like to begin actually on site here. If anybody has a question, you can speak into the microphone. You can certainly leave on your mask, but you have to hold down the button while you speak. So let's start with the room before we go to the Zoom. Any questions here? Matt, thank you.
I'll always get started at least. Rob, I love the quote that you used about the opposite of addiction is not sobriety, it's connection. And one of the things that Hari talks about in the book, in which I think maybe that was the first time he used that expression, it was the first time I had ever seen it at least, is the returning soldiers from Vietnam, many of whom had used heroin and other drugs while they were there. And yet if they came back into a welcoming environment, they had no trouble. And I'm just wondering, is that more apocryphal than real, number one? And if it is real, what does that teach us about the sort of power of a drug over the brain? Or as I think Dr. Volkow alluded to, the sort of specific, maybe personal factors, individual factors that might make someone more or less susceptible to becoming addicted?
That's a wonderful question. I'll take the first stab and then I'll let Nora correct me where I'm wrong. That's not untrue at all. That it's absolutely true that folks who are experiencing use disorders of all kinds, and whether that's heroin or another substance, do better in terms of treatment and recovery and sustained recovery when all of these things are being addressed, both the biochemical aspect of addiction to a substance. So it may be the physical dependence on heroin, the molecule, and that induces changes in the body, in your receptors, and you have an absolutely have a response to this, and it's pharmacologic, and withdrawal is real. But if those symptoms are less and the treatment is more successful, if people have community, if they have engagement, if they have forms of treatment that are known to be successful with both medication and psychological forms of treatment that are effective in their own right, and those things are combined, people's success rates are much better. And strongly predictive are things like community and stability of housing and stability of food security and job security and all these factors that are social determinants of health, rather than simply someone is addicted and you needed 30 days of treatment. 30 days of treatment isn't going to do very much for someone except start a journey of recovery where it may require a variety of different things, but without the accompanying community and social support and those other factors, rates of success are not great. They really aren't. They're not zero. But if you can add those things together and really do things well, and there's a few cases where you see cases where there are programs where people live and have extended treatment. People think 30 days is treatment. I've long thought this is craziness. 30 days is a start, and 30 days is an artifact of insurance coverage. 30 days does not have any basis in science of how long it takes a person to rewire their brain, plasticity, and be able to relearn habits and be able to move into a community of sustained recovery. So people think they're failing because the 30-day treatment didn't work, or it took them several cycles of this. And there are good data that if people have that level of treatment for 6 months, it looks a lot like the average number of times it takes a person to go through treatment before they're successful, 5.5, at 1 month at a time. So there's pieces of science that we know, but we need to apply them all like that. And some of the largest actors are not just simply giving them a medication-assisted treatment, which we can, or cognitive or dialectic behavioral therapy, which we can. But if it isn't in the context of social support and community, rates of success are just very low. So all those things need to go together, just like it's multifactorial, as Nora noted, on why would someone develop an addiction? It's not simply predisposition. It's not predictive by itself, factor. But so are people's social circumstances, their family circumstances, their existence of childhood trauma and adverse childhood experiences. All of those are predictive of people having use disorders.
Respond or take another question.
Well, I think that it is the way that the response is very accurate, and ultimately, for any disease, we tend to be very polarized and say this is a disease of the biology or no, it's not a disease. And in the case of addiction, is not any different. I mean, there's a lot of criticism of addiction as a disease of the brain, because they say there are extremely important social and cultural factors that drive drug taking, including that notion that I speak of as meaningful connections. But that doesn't negate in any way that that is a disease. I mean, it's just like in terms of obesity, you have to have an environment where the food is available. Otherwise, you do not have obesity. And that does not negate the concept that it is a disease. I think that it is notable in addiction. And the other aspect that we need to understand about addiction is that there's not just one road that leads you to addiction. I mean, sort of, there are people that have extremely supportive backgrounds that don't get exposed to adverse environments, and yet their vulnerability is so high that if when they start to experiment with drugs, immediately they escalate into drug taking and end up addicted, as opposed to others that may not have that genetic vulnerability, but stressors and deprivation and trauma increase their risk. So that is where you have the reality that yes, it is a disease, but it's also one where social and environmental factors are very important. I like to turn the table around and say, yes, the beauty of it is that those social factors are very strong and powerful therapeutic interventions that we can do to help someone achieve recovery. And if there's something that I think that, because obviously we all think a lot about what was this COVID pandemic experience for each one of us, one of the things that I think is positive is it has brought us together. It has made us aware how valuable those interactions are. And I think that overall, it has made us more attentive to the other. To me, it is so pleasurable to see someone because you are rarely seeing them. But that awareness about how powerful it is just an example that we as humans are extraordinarily social. And out of that comes our vulnerability, but also our resilience. And so to the extent that stigma interferes with that ability of basically bring the social construct in a positive way, whereupon why it is so crucial that we get rid of the stigma and why the work of Bill is so extraordinarily powerful, because it allows us to feel what it is. It's not indifference. It's not even a scientific separate thing from us. It's something that emerges inside of us.
Thank you so much. I'm going to turn to Malia. She's managing the chat we'll take a question, Malia, from the chat.
So we have a question and comment from Daniel Hebard, and he would like to direct us to Dr. Volkow. He says, I think people hear drugs are bad and automatically extend that belief to people who use drugs are bad. I wonder if changing the way we view drugs might change the way we as a society view drug addicts and help them actually recover rather than being driven further into isolation and worsening their addiction.
Yeah, no, it is absolutely an important point, and one that we need to face as a society. We want to address the issue of stigmatization. We equate drugs with badness, and therefore the person that takes them is bad. I mean, we don't do that with other diseases, and being able to clarify that something is the drug and the potential that the drug has to do harm, as opposed to the individual that is taking the drug. And there are many reasons why people take drugs, and though everyone says, okay, I make the choice of taking the drug for the first time, that also is somewhat not absolutely correct, because many people start to experiment with drugs when they are young and they are very curious, and it's part of our biology to understand the world. There's the peer interaction that leads us to want to take those drugs and be part of that culture without that knowledge that will come later. And so if you do have that vulnerability that leads you to addiction, you cannot sort of say that is a choice. And communicating this in ways that help destigmatize that whole process of the taking of drugs as something that is evil. And I think that that's where the whole concept it is. We as a society love to polarize. It's either evil or it is really the panacea of everything that's good that can happen to you with, for example, some of the pro-legalizers of some of the drugs. So we go from pendulum to pendulum, and we need to be honest. We need to actually bring up the facts and recognize that it's very rare that you have a black and white situation, and that our ability to really change things is by making an effort on comprehending that granularity.
Rob, would you like to weigh in and respond to that, to the question? Okay. Seemed like we had a sufficient answer there. We have time for one more question, either here in the group or through chat. So I'll open it up to make, to invite anyone here in the room to ask a question. Yes, we have a question. Wonderful. Thank you.
This is for both Dr. Volkow and Dr. Valuck. You guys both expressed some personal experience with addiction, and I know some of us here probably have as well, but is it going to take people like us who have seen firsthand who are the survivors of addiction and the witnesses of addiction to make changes in this country? Or do you see the country is finally starting to realize that we have a problem and actively be making changes as a country?
I'm going to jump into it because I think that, certainly the current epidemic that we are living is actually answering the question. It is so bad how many people have died from the opioid overdoses in 2020, 95,000 people. And actually, and what is different, of course, we have more than 600 people dying from COVID over, 1 year and a half, let's say 400, 500,000 people dying from COVID over the same period that we lost 95,000. There's also a difference there, and it's something that people don't completely comprehend. And those numbers, both of those numbers are horrific. But the ones on the opioid overdoses are being ignored because the COVID seemed so massive. People that are dying from overdoses are significantly younger than the people that have died from COVID. So if you look at age ranges, for example, young people that have died from overdoses from 15 to say 44, 54, there are more people that have died from overdoses in 2020 than from COVID. And that gets you an idea about how severe the problem is. And that's just from overdoses. It doesn't address other deaths. And this cannot be ignored. It's no longer possible. I think that there's one person dying every 6 minutes in the United States from an overdose, and the numbers keep on accumulating. And that's what has led actually to start to change the attention to the magnitude of the problem, which actually requires not just that we speak about it, but that importantly, we put the resources to address it, that we create policies that actually can help bring treatment to those that need them. So now it is illegal if you go to an emergency department and they do not provide you for treatment for your substance use disorder, whether you can pay or not. If you are not provided that treatment, that emergency department is actually going against the law. So creating these policies, producing the resources, educating the healthcare and support staff that's necessary to bring the needs of people that are suffering from addiction. That's what is actually a reflection that people, even if they have not had the experience, are starting to realize that we cannot afford to ignore addiction anymore.
And I would just echo what Dr. Volkow says, that it really has gotten to the point of beyond epidemic proportions. And I think, as some have said, it's maybe 2 degrees of separation between yourself and somebody who has a use disorder. It's really hitting home. I think most people, you can talk about that. I don't think there's a person I talk to that does not have an example in their own family somewhere. And when it's at that level now that it's affecting all of us, I think it gives us the ability to give it more attention and to affect some of these policies. Like she mentioned, we've made a lot of progress here in our state in the last 5 or 6 years, more than we did in the 30 years prior. I've been doing this my whole career for over 30 years. And just in this last 5 years or so, have we really started to make some meaningful progress with both improving medical care and addiction treatment, in systems for trying to expand access into rural parts of Colorado that have no access to treatment whatsoever. Things that are actually encouraging, that we're going, we have a long, long way to go, but they're encouraging that we're starting to pay that attention to it. So, sort of the bookends of the messages, one about how bad it is, but on the backside of it, that there is hope and there is progress, and I think we know what to do. We just really have to lean into it and do it.
I want to thank both Doctors Volkow and Valuck. Dr. Valuck will stay with us for the rest of our time together, but I know that Dr. Volkow will be getting on with her evening. She is a couple hours ahead of us. We really appreciate your being with us tonight. We wish you all the best. Thank you again for spending some time with us. Thank you so much.
Thanks very much, and good night to everyone.
So I'm going to ask Simon Zalkind, our curator, to step up and talk about the art and put some of Bill's work in an art historical perspective. So Simon.
Thank you, Tess. I feel a little silly, a little frivolous talking about art after the previous two speakers addressed us to very profound and aspects and dimensions of this phenomena that seem as though art couldn't possibly encompass or address them in any meaningful way. So while I can't say that there's a history of art about addiction per se, there's definitely a long history of art about mental illness, mental distress. And I just wanted to show a few slides. In some ways, they're almost arbitrary. I can't read what I wrote. I remembered my hearing aids, I remembered my notes, but I forgot my reading glasses. This is essentially meant to give you some sense of a range of how artists over time have addressed issues of mental illness or mental distress. I've also included some images that purely respond to the fine art dimension of what William is doing and have, at least I hope, nothing to do with mental or psychic distress. So, David, if you could. Oh, okay. Well, this is really interesting. This is by William Hogarth, who was a great social satirist in the 19th century in England. And this is called A Rake's Progress in the Madhouse. And I wanted to include this because I wanted to demonstrate how within relatively modern times and in our own culture, people in immense suffering were pent up in warehouses, so to speak, but further were a source of entertainment for aristocratic and wealthy people of the area, visiting Bedlam to see the insane was a fine thing to do on a Sunday noon after church. So the idea of the insane, or maybe a better word within this context would be people possessed, because I do think that in some sense, addiction can be seen as a form of possession. And I think possession is actually art historically where I find the closest resonance. And of course, it was often interpreted through a religious lens. Can we go to, okay, the next slide isn't exactly that. Okay, this is a work by an artist named Egon Schiele, an Austrian artist in the 19th century. And I was struck by it because I think even though the name didn't come to mind immediately when I was looking at the paintings, there were any number of them in which there was a skeletal and spidery hand raised to kind of cover the mouth or obscure the face. And I thought, is this someone trying to conceal something? Is this a gesture of concealment? Or is this the stifling of a message, a scream? It was a very poignant and powerful image for me. I don't know, I haven't spoken to William about where that derives from, but when I saw it, I immediately thought of Sheila. Also, as you can see, his subject has his own degree of problematic mental states. Okay, can you go on? David, please. Oh, I do. Right. Okay. Another icon, Sheila, again with the skeletal spidery fingers held to the face. Both of them very reminiscent of images in the gallery. Okay, this is pretty interesting. This is by an artist, actually not an artist, someone who in the day was called an alienist. Alienists are precursors of what we call psychiatrists. And I always thought it was interesting that they were called alienists, alien from whom? Do they treat people who are alien from themselves? The origin of the word was obscure. But this alienist, whose name was Jean-Étienne Dominique Esquerol, was a French alienist who specialized in drawing and rendering his patients, particularly those in states of possession or hysteric possession. And this is one of them. So I wanted to include that as being part of a lineage of how artists have dealt with mental illness. Okay, this is This is a painting by Jan van Eyck, probably I think 17th century, maybe 16th, and again it's people in enormous states of mental distress. And again, it was interpreted and shown through a religious lens. These are souls in purgatory. If you look at them closely, each of them is individual and is kind of isolated within the context of their own suffering. But this is how people in the throes of possibly addiction. We all know about Saint Vitus dance. Saint Vitus dance has its origins in a mold called ergot, which was distributed through the bread, which was then disseminated through the community. And ergot is essentially where we derive or can extricate a more complex molecule from, but it's LSD. So whole towns would be possessed by having eaten the bread. And there would be mass mania. And so the idea of mania and possession struck me as being very similar, not, an exact parallel, but very similar to what we're talking about. Okay, I'm gonna try to go next. Another, this is a painting by Grunewald, and it's The Temptation of St. Anthony. And in the right panel, you can see the saint in discussion, possibly with another hermit, possibly with a less benign figure. But on the left, you can see him assailed by demonic forces. And, you know, although it may be a metaphor, it's a handy one. And no doubt people experiencing this did interpret their experience this way. So, but again, I see this in a lineage of how historically, artists have dealt with mental illness, with mania and possession. Well, okay, there's Edvard Munch. Everyone knows this painting. I mean, this has been made into pillows, punching bags. It's the profundity of it and his unique capacity to capture in this very visceral way the experience of anxiety, of being assailed by anxiety, is unique, particularly in modern and contemporary art history. And Munch did a number of images of anxiety. He is the artist of anxiety. And he kept returning to the theme. Again, I thought that linked very nicely with our exhibition. Next, please. Another, Vincent van Gogh. I think between Van Gogh and Munch, the thing that kind of not worries me, but that I occasionally think about is these two artists, in a sense, have romanticized, and a lot of artists have done this, but Van Gogh and Munch in particular present a very romanticized idea of mental suffering, and one that has become, you know, images that people think of almost as a decor, you know, and, you know, posters. These are reproduced in any number of mediums, and many people have them decorating their homes. They're profoundly distressing to me, and I wonder if some of that original distress that the artist intended didn't get lost in their becoming popular images of distress. So, okay, next. Okay, this is a really early image, one of the first I remember ever encountering of someone in despair, and it's by Albrecht Dürer, and it's called Melancholia. And I think we can easily sort of pick out the elements of isolation, of inwardness, of unhappiness, of lack of any inspired way to move forward. She's very much a contemporary person. And Dürer captured her psychic limitations, let's speak. She was a melancholic, which would over years become a hysteric. And, you know, the names for people who were profoundly unhappy changed. Next, please. Okay, this is by a contemporary artist named Tracy Emin. And it's, believe it or not, Tracy Emin was one of a group of young British artists that emerged in the 90s. I think they were called Bad Boys, but she's a girl and a woman. And I think her great accomplishment in this piece is to do a self-portrait in which a person's, the extension of themselves into their immediate environment as much describes their condition and their state of mind and their suffering as a full-on portrait of a head, which of course, you know, of a face, which we generally happens from the torso or the neck up. So the notion that this environment speaks for how she feels, who she is, and what she looks like was really, I think, a breakthrough. Next, please. Oh, this is an artist named Ali White. You know, I'd never heard of him. I found him in an article on contemporary artists and mental health. And I just thought it was a powerful image and also has some obvious relationships to the subjects of the exhibition. Next, please. Okay, this is a piece by Francis Bacon. And to me, Francis Bacon is the artist of anguish, contemporary artists of anguish, despair, and distress. He was himself an addict, cross-addicted to a number of substances. This may not be relevant, but the paintings go for billions of dollars. And a number of them are named after various popes. I think this may be Pope Leo, I'm not sure. And I really should have done more research as to how his images acquired these papal designations. And also, I think very visibly, very viscerally, it demonstrates a clear connection to the kind of mental state, the mental condition that we confront in the images in the gallery. Are there any others? I thought there were 2 Chuck closes. Thank you. Okay, at this point, I wanted to address not so much the psychic and social and mental aspects, but I wanted to actually speak to things that came to mind for me in William's painting. And I don't know if many of you are aware of an artist named Chuck Close, tremendously accomplished portraitist. And one of the things he did was, can I see the second slide? Is he made portraits, which are typically intimate, into these institution-scaled images. And when I remembered them, I thought immediately of William. I don't know, William, if you've derived any, if you've ever looked at Close's work. But the other thing, and can we go back to the previous slide? At one point in the 80s, Chuck Close had an aneurysm and was paralyzed from the waist down. And so he could only paint with a brush attached to a device that was attached to his arm. And what he began to do conceptually, he'd been doing this before, but now this was the only way he could work. He would impose a grid or some kind of structure on the canvas. And within each element of the grid, he essentially made what was a self-contained abstract painting. But when you put it all together, it almost looked hyper-real. And I thought to myself, what if you were to take one of William's paintings, not that we'll do that, and superimpose a structure? Because I was so struck by how dynamic and abstract passages of William's paintings are, that if you were to abstract or in some ways isolate a passage or a square, you'd come up with a credible painting on its own, beyond the fact that putting them all together, we had a very, very powerful, and in many ways, I think, utterly realistic, if not photorealistic, realistic in a way that may go beyond the kind of slickness and the tour de force of the technical means achieved to to do a portrait like that. So this is in a way something I just want to offer you as a possibility. And it's something that I hope William and I will maybe address when we chat. So I have to tell you, this show is a dream for me. I was directed to William by Sandra Furman, who's the director of the Colorado University at Boulder Art Museum. And, you know, she just nailed it. You know, she knew of my interest in art that addresses or responds to bioethical themes. And this was just a great gift. And William was just a pleasure to work with. So thank you.
Simon. So I'm going to ask Simon to stay where he is, and Bill will come down and socially or physically distance from him so they can have some conversation between the two of them. You've got a mic there. And if you will make sure you speak into the mic.
Like this.
Okay.
Yeah, we can hear you.
Simon, right off
Yes.
the bat, can I address a couple of things that you actually put forward as questions or things that you were wondering if I had done or thought about? Can I just rattle off
Sure.
what those are? The first one was hands. I'm definitely influenced by Shealy.
Okay.
No question about it. And so his hands, the way hands are very difficult to paint and draw. They just are. And Sheila's are very expressive and abstracted. So he's got these bent fingers, and he's done all these things with them that take them a little bit out of this era, this notion of photoreal. And so I can kind of get away with some things. But on the other hand, I can abstract them and give them more emotion. And so he really appealed to me. There's another South American artist, Oswaldo Gayasimin, and he does the same thing with his hands. And so I picked up on them right away. The hands to the face. Oh, I'm gonna tell you one other thing about why I started with hands. I was painting faces. And if you look at my older paintings, they don't have hands in them. And so one day I just said, it's starting to get boring. I think I'll give myself a challenge and draw some of those hands that are really difficult to do. And that's purely how it started. But once I did, I could start bringing up to the face. And you were right on with some of my intentions. And I let you decide what that is. But on some of those, I'm saying I'm silencing this person. So one of the paintings in there is a big red streak across the lips. I'm silencing her. And I'm making a statement. And so with others, I did it with hands. And so that was definitely part of it. And then it kind of became part of, well, I'm shielding my face. I'm hiding myself. I'm embarrassed. I'm evil. And that just kind of fit into what I was doing. And so for all the reasons you noted, I was doing that. So that runs through these paintings.
I also, it occurred to me that they were not healthy hands. They were spidery and skeletal. And in that sense, I saw them as an extension of the person's larger display and their face.
Absolutely. So hands and faces are so expressive. So if I am creating someone that, well, I'm going to contradict myself a little bit, but I'm going to go along with what you're saying. With someone that has some stress, I'm going to show the same thing in the hands. And so that's all part of the same reason why I'm doing hands, that it's one other way for me to express how this person is feeling. So that works. Okay, the tortured souls. This is the part where I'm going to contradict myself a little bit. Something that I've really tried to do is create ambiguity so that you assign the feeling to this painting. And that's why the woman that I spoke of earlier that looked at the painting one time and said that, you're describing me, I want to die. And the next day she looked at it and saw hope. That's what I'm trying to do with every painting. I'm trying to create an ambiguity that you complete. You establish what's going on in that picture. And then I want you to change it the next day. And the only way I can do that is to give you kind of a blank slate in the image. And so I believe that you assign how that person feels. Now, that isn't the case with every painting. And some of them have more of an idea, a passion, and emotion that sticks with it. But a lot of them don't. And people describe that to me then, how they'll look at it one moment, they'll come back the next day and look at it, and they see a different painting. And it's based on their feelings projected on that painting. So I'm trying to do that. Our brains do not like ambiguity. So we like to finish puzzles. So if I give you an ambiguous, almost blank expression, you want to fill in the blanks and create that emotion with that painting. The other thing is so I'm watching the slides go up there, and I'm agreeing with everything that Simon's saying. And then I thought, but I'm not a tortured soul. And those of you who know me know, at least externally, that those paintings aren't reflections of my personality. You probably couldn't say the same thing about Schiele, Munch, or Vincent van Gogh. And so I'm looking at this, I hope, a little bit different way. The last thing, you mentioned Chuck Close. And of course, I research and follow Chuck Close very closely. It did. And people immediately say, oh, your stuff is just like Chuck Close's. And of course, I say, no, it's far from it. And this is why. We both paint these big faces with a composition that's very similar. It's a face that's filling up the entire painting. Well, very early on, when I started doing these 7-foot faces, I said to myself, 7-foot face, that's a 4-foot forehead. What the heck am I going to do with a 4-foot forehead? I mean, is it just going to be blank? I'm going to put lines on it. How am I going to complete this and make it interesting? So I decided, and you mentioned abstracts, I decided that forehead, cheek, chin, they were all separate abstracts. So if you look at those paintings in there, you will see that the forehead is completed frequently very different than the cheeks, and that the way I composited that painting is very different for those segments. So I said, up close, I want you to see this nice abstract of this forehead. Going back, you're going to see the entire face. And in some cases, it is photoreal. Chuck Close was an expert on something called global versus local vision. Global vision is that you step back from the painting and you see something that looks photoreal. Local vision, you go close to it, you see something entirely different, and that's the grid with the little symbols in it. Well, I don't grid and I don't use little symbols, but in a way I do use symbols. So in other words, if you go close to my paintings, you will see that I've got all kinds of marks, and dots, and spills, and smudges, and sandpapering, and all these little things that complete a cheek or a nose or a forehead or a chin. When you look at it, it is a separate abstract, but when you back away, it's very different. And so I've certainly learned from him, but I've carried it out in a different way. I'm not the kind of person that does a little grid and fills it in. I'm a slasher, but sometimes I'll do it with a brush. So, okay.
Okay. One thing that occurred to me when we were hanging the show, although you and I haven't spent an inordinate amount of time together, you strike me as a pretty, as a pretty well-adjusted, as a person at peace with themselves, their work, who leads a meaningful, pleasurable life in community, family, and relationship. How did you put yourself among these subjects for whom those things are very remote possibilities? Why did you place yourself? among them
Yeah.
in 2 paintings.
Well, I'm starting to do a video of my self-portraits right now. It's a new media presentation, and I've done 21 self-portraits. And the 2 self-portraits are in there, share a feeling, but a very different style. I just felt that I was part of this entire endeavor. I have been a witness. And so I thought it was fitting that I put my own portrait in there. The other question you've got is, I truly believe that you take the good with the bad in the world, and you can't survive the bad if you don't have the good moments. And so if I'm, in some way, I say that if I'm not a happy person, I can't do these paintings because I couldn't get through it. And then I would be like Vincent van Gogh or Monk or, you know, and so for me, it's my way of dealing with a subject matter that is such a downer. And yet I can do it because I've got the other part of my life that keeps me going.
Well, speaking of keeping you going, do you see this series going forward?
Oh, absolutely. And
where
so,
do you encounter your subjects?
on the street in Boulder or in a coffee shop, or so all of the subjects, all of the paintings have a title that's the sitter's name. So all of the self-portraits are Willie. So I'm the sitter in front of a mirror. And all the other ones are people I met at a coffee shop, met at the gym. They may have modeled for a group of artists, and I may have met them then, and then I'll ask them if they'll sit for me. The other thing is that we tend to stick over time painting, and they become personal friends of my wife Mary Kay is in mine, and I really get to know them. And of the people that are in there, I maybe know of a couple of them that have had some issues with drugs and alcohol, but I can't say the others have. I don't ask them, but if someone says something and I have some inkling, I know that. But I have a feeling that's no different than society at large. And so some of them are very adjusted people with families, and they sit while I paint.
Well, William, this definitely feels like a calling for you. You know, it has that feeling for me when I hear you talk about it and look at the work. There isn't any aspect of it that's, you know, frivolous or even playful, although I guess one could tease those elements out of some portions of them. But what interests me is what came before? What kind of work were you doing before your sister OD'd?
Yeah, I was doing Caribbean dancing women. Okay, so when, this is no joke, when I started painting, we were living in the Virgin Islands. And a couple things. First of all, when I was, how did I say that in the beginning? In 65, I was 17. You know the Jackson Browne song.
Yeah.
Okay, so turns out I was 17 in 65, and I wanted to be an artist. And I loved Jackson Pollock and Willem de Kooning and Franz Klein. And you know, the abstract expressionists were what it was for me. I loved it. And when I talked to my high school counselor about, you know, going on to school, and my parents came in for the discussions, they kept saying, no. You want to be a commercial artist, and you want to do, in fact, they had arranged for me to meet the commercial. Okay, I grew up in a town of 5,000 people, all right? We have a weekly newspaper, and there was a guy who worked at the newspaper, and he drew ladies in dresses for the dress shops and things like that. And that's who they wanted me to talk to. And I'm thinking, this guy is not Willem de Kooning or Jackson Pollock, and there's no way I'm going to do this. Well, lots of things happened. I didn't go to art school. I became an engineer instead, and I really didn't do any art. And so then 40 years later, I decide, okay, quitting the job. I love this job. I'm quitting it because I'm going to be an artist. And so we're living in the Virgin Islands, and I did some paintings, and it was small, it was very colorful, Caribbean colors, pinks and beautiful greens, and these the blue that I saw in the sea. And people bought them, so I did more of them. And I got some shows down there. So I was painting these paintings that visitors to the Virgin Islands wanted to take home. They were down there for their anniversary, and they saw a picture of a dancing woman in a bright dress by me, and they bought it, and that was great. And I had a show in Denver. And I show at Space Gallery in Denver. And the guy who owns Space Gallery, and I was talking to him after one show, and I said, I'm really getting bored doing this. And he said, you really do faces well. Why don't you do some big faces? So I started doing the big faces. And about the same time, my sister OD'd. And so the big faces took on a very, very different look. And I ran with it. And I started with 4-foot paintings, big faces. Then I did 5-foot tall paintings. Now I'm doing the 7-footers. And I ran with this. And my sister's death had a profound effect on my work. And for me, it was what I needed. And it gave me my voice, my mission, my direction.
This is something, well, the first sentence is something that I wrote in my notes on my way back to Denver from having first visited you in Boulder. And I wrote, I wasn't prepared to be gut punched by every painting that William showed me, simultaneously riveted and relieved to be able to turn away. The oversized portraits, most of them 7 feet by 5 feet, are painfully intimate, simultaneously seductive and confrontational. They're difficult to look at and difficult to turn away from. As Susan Sontag remarked in her Regarding the Pain of Others, the iconography of suffering has a long pedigree. Can you look at this? There is the satisfaction of being able to look at the image without flinching. And then there is the pleasure of flinching. And that's not something that necessarily is something we can resolve, but to hold both those possibilities simultaneously, I think one of the great successes. If anyone has any questions.
Thank you.
Thank you, Simon. And thank you, Bill. We are getting close to end of time. And so with that in mind, I'd like to invite maybe one question from our live audience and for any of the 3 presenters here. And then maybe one question from our chat. So anyone here in the live audience have a question for Bill, Simon, or Rob before we go remote? Okay. All righty. Well, I'm a teacher, so I can just stand here and look at you for a long time. However, I'm going to, in the interest of time, and it's been a very full evening, we will take a question from the chat. And I think this is a question for Rob, is it not? It's for you.
It is. This is a question from Arturo Garcia. He is asking, do drug addicts and alcoholics suffer from the same ailment? And is alcoholism and drug addiction one and the same, or are those separate things that require a different approach when seeking recovery?
Yes, that's a really good question. There are many similarities, regardless of substance, that the way that the professions, health and medical professions and science sort of see them is that use disorder, substance use disorder is a broad term, but because there are many commonalities across substances. There are definitely the physiologic effects of the substance, but then there's the biopsychosocial and all the other things that are involved in genetic and all the other components. So there are definitely similarities. And that does drive similarities in treatment in a broad sense. But there are uniquenesses as well between, whether it's alcohol or an opiate or a methamphetamine or another substance, that the way they act on the body has its uniqueness, whether it's a stimulant or something that's a sedative or something that's an opioid that acts on pain signaling. So there's just differences in the way they work that can then drive differences in the way treatments are prescribed and developed for people. So it's a little bit of both is the short answer, that there are some commonalities to use disorders of all kinds, but then there are some uniquenesses about how you treat individual ones.
Well, thank you. Thank you, Rob. I want to end with agreeing with my colleague, Simon. This exhibit is a dream, not only because we were able to open the art gallery again with your work, but I also think that this conversation that we've had this evening is a dream, one that we've wanted to realize, and we have tried to realize throughout all the work we've done here, where we've had substantive discussion, we've learned new and taken away new information. We've certainly celebrated the power of art as an advocacy tool, but also as a way into the kind of emotional complexity of human experience. So please join me in thanking our guest tonight, artist William Stoehr, curator Simon Zalkind, and our colleague from pharmacy, Rob Valuck. Thank you. Thank you all for being here. Good night, be safe, and we will see you. And please invite your colleagues to stop by the gallery, your students, and we hope to see you again soon.
Thank you.